welcome to The Digital Patient, where we discuss the latest advancements in digital patient engagement and share stories from the front lines. I'm your host, Alan Sardana, and with me as always is CMIOs MD's CEO, Dr. Joshua Liu. Today we're joined by our very special guest, Dr. David Chestek. Dr. Chestek is CMIO at UI Health, where he works to bridge the gap between health information technology and clinical medicine. He also maintains a clinical practice in emergency medicine. Dr. Chestek, David, welcome to the show.
Thanks so much for having me.
It's awesome to have you on today. We're so excited to start the conversation. I kind of wanted to dive back to your roots in healthcare and actually before healthcare. I noticed you initially pursued biomedical engineering before transitioning into medicine and informatics. So I was really curious to start the conversation there, like what attracted you to that field and how did this background in engineering help influence maybe your approach today that you have as CMIO?
Yeah, I like to think of that as the origin story. And we all have different origin stories. And I think for me, I was not all that directed when I was headed into college. Like I didn't have a clear vision about what I wanted to do. I did have a lot of engineers in the family. My grandfather did engineering. My sister was an engineer. And so there was a sort of general idea that the principles and the way that you think about problems is important to learn. And so engineering in general was what I wanted to do when I went into college. And then when I started, the field of biomedical engineering was relatively new. And so it was an introductory course. I took that and I was like, this is pretty cool. You know, you can do engineering type science on the human body. And so that sort of grabbed me. And then as I got closer to graduation, I started getting more deeper into the coursework. I thought this was really interesting. But when I started going to job fairs and figure out what I would actually do as an engineer, I was like, I think I want something a little bit more personal than this. But I never really lost that engineering mindset about how to approach problems. So I sort of switched to pre-med halfway through, did my coursework, and then ended up in medicine, where I was actually a little frustrated about the medical school curriculum focused a lot on memorizing facts and spitting them back out, and not as much on the sort of engineering first principles. You know, like you get your equations on a piece of paper and it's about how you apply them, not whether or not you remembered the equations. I feel like I've taken that approach to medicine once I got beyond medical school, because that is actually how you practice medicine. You have all of your equations in front of you and then you generally have to figure out what to do next. I've taken that engineering principle, but it definitely helped inform where I wanted to go, but I didn't want to do it long term.
Yeah. And when did the appearance in informatics happen in your life?
Yeah, I think a fair number of CMIOs have a similar story, but there was a go live happening at a hospital where I was a resident. And it was, I even forget which medical record system. I think it might have been McKesson that we were going live with, but we were doing it in the ED already as a residency. And the upstairs floors weren't doing it yet. And so they came down and said, hey, I need a super user and I need to teach these doctors how to use this system. And by the way, we'll pay you. And I was like, sold. So I went up and it was a really interesting experience for me, not just because I was making a little bit of extra money, which was nice, but I really liked the expanding out of now I get to see what the whole hospital is doing. You know, I was sort of stuck in the downstairs. Now I know, like I saw a patient that I had seen and intubated the day before in the ICU. I was like, oh, this is like, continuity and how are other people caring for this patient? And by the way, there's a whole lab system. There's a pharmacy system. Like it sort of blew my mind about how complicated the hospital was and how it all had to fit together. And I really liked some of the problem solving, issues that come up during a go live. So I sort of caught the bug of informatics there. And then sort of by chance, I guess, I was reading one of the throwaway magazines that you get as a specialty for emergency medicine. And I saw a little column in it about informatics. And I was like, this is a thing. This thing that I had been dabbling in is now a more formal fellowship. There were, I think, 2 or 3 fellowships at the time. And one of them was at the University of Illinois in Chicago. So I decided to apply to that fellowship thinking, I want to learn more about this stuff. Even in the emergency department, I found myself getting into conversations with the other attendings and residents about the EHR. It was the thing everyone was either frustrated about or sometimes excited about, but it ended up being a big driver. And so I did a 2-year fellowship at University of Illinois and then graduated with a fellowship in clinical informatics. And I stayed on at University of Illinois as faculty doing some basic analytics stuff for the department, helping with staffing models and throughput and things like that. and then was in the fortunate position right after I graduated where our hospital system was transitioning from Cerner to Epic. And it was a pretty big transition. We had about 30 years of legacy data and a lot of customized stuff in Cerner because we were one of the earlier sites on Cerner. And as a result, we would notice a problem and say, hey, Cerner, I wish that you did this. And they were like, well, we don't do that yet. We'll work on it. And so then we would develop our own solution, which was cool and innovative. But then we sort of diverged from what the standard Cerner install was. And so we were at a point where we couldn't even take any additional upgrades because our system was so different than theirs. So we kicked off a big RFP, and then we ended up selecting Epic. And so I was sort of newly graduated from fellowship with this big institutional project going on. And so then I got involved on the inpatient and critical care side, or like the acute care medicine and inpatient side of that install. And I had an ambulatory counterpart. And then after that install, he veered off more into the general admin and leadership side. And I got more and more focused on informatics, and then expanded out to now become the more enterprise CMIO.
Today's episode is brought to you by DeepScribe, AI clinical documentation that physicians and health systems love, documenting specialty and complex care with ease and precision. Josh, have you heard all the buzz around ambient AI and virtual scribes?
Definitely. Clinicians are spending hours a day on documentation, so improving their day-to-day and reducing burnout is huge right now. You and I have seen quite a few product demos for ambient this year, but I have to say, DeepScribe was one of the most impressive.
Well, Josh, you trained as a clinician. What stood out to you most about DeepScribe?
Well, using AI to transcribe and summarize the clinician-patient conversation is honestly table stakes right now. But a big challenge for CMIOs and CIOs is driving actual clinician adoption. So what really impressed me about DeepScribe is how well it can be customized to different specialties and workflows with dozens of templates as starting points. That would be critical to me as a clinician because I just don't have time to build templates from scratch.
So true. For me, I was particularly impressed by the auditable notes. You can highlight any part of a note, and then DeepScribe shows you exactly where in the transcript the note was generated from. So you can find that evidence right away. That builds trust.
Oh, exactly. Being able to confirm that something wasn't hallucinated is so important for clinician trust and safety.
Yeah, that same attention to detail that led to really high clinician adoption is also resulting with clinicians saving up to 75% of documentation time.
Wow, that's incredible. But how is DeepScribe's accuracy with specialty care or complex cases?
That's the best part. DeepScribe's proprietary LLM, Heal AI, is trained on over 3 million patient conversations. It's then further tuned by specialty and subspecialty cases, making it way more accurate than GPT-4-based solutions. Pair that accuracy with DeepScribe's customization studio to personalize the experience for different clinician preferences and workflows, and it becomes incredibly flexible.
Alan, speaking of flexibility, I could use some yoga myself. Flexibility is key when it comes to working with health systems with so many moving parts. DeepScribe sounds fantastic. Where can health systems learn more?
About your yoga? I don't think they want to. But about DeepScribe, check out deepscribe.ai. That's deepscribe.ai to learn more. So earlier in the story, I take it you were one of the excited folks around the EHR rather than the ones complaining. You struck me as the super user in the beginning. I'm really curious, when you were stuck down in the emergency department, given that that's where you still are clinically active today in emergency, what sort of unique insights and advantages do you think that brings as CMIO for the whole enterprise now?
Yeah, I think, I might be biased because I do enjoy my profession, but I think emergency medicine docs make some of the best CMIOs or just in general administrators because we see so much of the healthcare system. We're somewhat of a safety net. And so when people aren't able to access the system in the right way, they have a problem, they end up in the ER because it's the only place that they can go. And so we interact with inpatient consultants, we interact with ambulatory providers, whether the patients can get access to see them or not. So whenever something falls through the cracks, it ends up on our plate. And so I feel like we have such a good global perspective of the healthcare system. Now, with that being said, you don't know everything about the whole healthcare system. I just worked in the ER. So some of the areas that I've had to learn how they operate most are surgical specialties, for example, because it's just such a unique breed where they have an outpatient clinic mostly to schedule inpatient surgeries. And that workflow is totally foreign to me. So I've had to spend a lot of time getting to know some of my surgical colleagues. I don't have an ambulatory clinic, and I try to spend some time with some of my ambulatory friends as well to learn some of their struggles. And so I feel like everybody comes into a CMIO role with some operational experience. And I think the ED provides you a broader depth than most, but it doesn't get you everything. And you have to always make sure to reach out to the folks who are living it and go sit next to them and watch what they're doing.
I'm curious, like, did you end up having to have, I guess let's call it informatics champions in each clinical specialty? Is that the structure you're in now? Or if not, how do you sort of get that regular feedback from the different clinical subspecialties?
Yeah, so for our go live, we sort of broadly did inpatient and ambulatory. And then I pushed for our implementation to also have a surgical champion because I learned very quickly how unique that whole space is. And so the structure that we're trying to set up now, and it's still a work in progress. I don't know of any informatics structure that is flawless, but trying to separate it out into those three big buckets. So I try to focus the most on enterprise issues. And then there's folks who spend some time on inpatient, ambulatory, surgery. And then I also want to add in a quality focused person just because there's so much data and workflow that comes into quality work to make sure that we're getting credit for all the good care that we provide. We're potentially going to embark on some enterprise imaging transformations. And so the whole imaging space is a big space that I think it's be important to get some clinical specialties in. And then sort of one layer below that, on the super user level or the physician informaticist level, I really am pushing our clinical departments to have at least one person per department to be sort of the spokesperson for that department to help triage issues, share the knowledge that they learn with their peers, and help bring a voice to their specialty to say, we're really struggling on this thing. All of us are feeling the same way to help coordinate things. So I try to have one person per specialty. Sometimes that's more successful than others.
You brought up some of the transformation you're thinking of when it comes to imaging. Could you unpack that a little bit more? It sounds like a pretty big, exciting initiative underway.
Yeah, I'm learning a lot more about it in recent times. So I am by no means an expert, but it feels to me like the imaging space is sort of in the place that the EHR was 10 years ago, where there were a lot of different vendors out there and everyone was doing something different. And then they were all kind of bolted on to each other with a lot of interfaces. And so that's the way a lot of the imaging systems are now. And in the same way that these big systems are now coming together to pull them all together into one space, that's happening in the imaging space as well. So we're trying to consolidate the cardiology packs and the radiology packs and the OB packs and ophthalmologists who take pictures of retinas and the endoscopy people who take photos and put that all into a vendor neutral archive, and then have just a viewer sit on top of that flexes per specialty, but not necessarily having these 8 or 10 separate systems. So I think that'll be an interesting journey, but it doesn't feel like the industry is quite as mature as the EHR industry is either. So there isn't really one system that can replace all those things, but we're going to move there cautiously, I would say.
Yeah. So as someone who definitely does not know the history of imaging and the PAC systems, it sounds like a lot of solutions were developed that were very specialty, point solution specific, but probably very good at those. But as part of, I guess, the transformation going on, it's a question of how do we consolidate? Is that mostly to lower kind of the operational cost, the overhead of managing all these systems, or is there another kind of reason? Like maybe it's, hey, we're actually trying to apply some, analytics or AI on top of that, but it makes sense to only do that at a platform-wide scale, so we have to consolidate. I'm curious if there's other reasons besides, overhead and cost that it makes sense to try and consolidate that.
Yeah, I think for sure there's an overhead and cost piece. That's sort of the easy thing. There's also the practicality of the more times you bolt things together and interface them, the more often they break. So that's partly the maintenance which you could put into the interface or the cost and the overhead, but it's also just frustrating when things don't work as well. And so I think it's going to be a better experience in general once we get everything on one platform, or hopefully less platforms. But then to your second point, for sure, the ability to have everything in one spot, that vendor neutral archive, I think, opens up a lot of possibilities that we don't have today, particularly for research and analytics and AI. And a lot of these vendors have the capability of automatically stripping all the identifiers. You have the patient's name and things like that on a chest x-ray, but there are lots of platforms that can strip all the identifiable information and create a research data warehouse on some of this really rich visual data that you can pull now out of the EHR. It's just a lot of work. and it's not standardized. And so it just makes these things work better at scale. So I think it's definitely cost. It's also potentially usability and forwarding our research and innovation.
It sounds really beneficial that you cut your teeth with the Cerner, bolted on with all these different optimizations and upgrades, because now you can have a set of rules moving forward with the new Epic instance and how you're going to approach scale and one platform and consolidation of all these different point solutions. I was curious to kind of pick your brain a little bit in terms of the timing when you became the CMIO. It was a significant undertaking, and then COVID hit. So I'm curious, how did that experience shape your perspective on healthcare technology, informatics, and how you're focusing today?
Yeah, definitely trial by fire. I think that entire implementation deserves medals, every single person who is involved in it, because for those of you who have been involved in an enterprise transformation, it's always a lot of work. It's a huge endeavor, and it's, a couple year long process. And then our original go live date was May 9th, I think, 2020.
Wow.
And so, in March and April, we're hearing rumblings, and then we're like, is this really a thing? And then we had the fateful meeting where we said, are we going to really postpone our go live? Like, this is something that we were never going to do. There's a hard line, we will go live on this date. And we had lots of maintenance contracts that were expiring that time. And we took stock of things and decided, this is just not a safe thing to do right now. And so we pushed it to September. We then were in this very difficult position of having our old Cerner instance and needing to be pretty nimble and adaptable with it, building new COVID tests, making sure we had accurate reports as we're transitioning. And then we transitioned. It's not like COVID was gone. So then we had to sit in the two systems and make sure that the data was flowing over correctly. And then to make matters more interesting, on our go live date, we had 3 different labor unions take work stoppage. So we had a global pandemic and a large work stoppage at our organization on go live date. I remember sitting in the command center with protests going on outside and wondering if this was the end of days. But we made it through, and I think it definitely has shaped my view on these things. We made it through that. We can make it through almost anything. And the other takeaway I would say is that leaning into this technology really helped us to provide amazing care. It doesn't matter which EHR you have, but if you optimize it, it is really another lever you can pull during some of these crises. I mean, we were able to stand up large vaccination centers, roll out my chart to folks and send them text messages and get everybody vaccinated in the population, mobile clinics. This is really another tool in your tool belt as a physician. And that's why I got into informatics. I felt like this is such an important tool that, not to say it's as important as an actual medication that saves a patient's life, but if you don't use your technology well, you are not serving your patients well, you're not serving your physicians well. And so I think watching that impact during this very complex install has definitely shaped my perspective and given me hope that technology can be used for good.
David, as you were describing the delay of the go live, I had this terrible analogy come to my head. So I was supposed to get married in the summer of 2020, and then we postponed our marriage go live to November 2020. Sorry, terrible analogy, but it just came to mind when you were describing the delay in the go live. But one of the things that you said that really struck me was this idea that given how complicated and difficult it was to go live in 2020, knowing that your team could do that, anything that might come up in the future, it feels very attainable now because you've been through the ringer. So I thought that was a really, really great lesson. I appreciated that. Even before the pandemic happened, you've been doing some research on burnout, and then you've mentioned in the past how COVID basically became the perfect storm for exacerbating, burnout and hurting clinician well-being. Kind of curious how you're thinking about using technology to address clinician well-being and burnout today, and what might be on the horizon for the team at U of Illinois.
Yeah, no, I think fundamentally a lot of us get into informatics because of burnout. I hear people complaining about the system and why it's bothering them. And that's part of the reason why I got into informatics, because I felt like on the one side, they were right that the system needs to be better. And so I wanted to be in a position to advocate for what those changes should be and help shape it. And on the other hand, there's also oftentimes a lot of things that you could do if you just knew about it. And so I really wanted to focus on those folks and say, the system isn't perfect and we'll continue to advance it. And I want to be part of that conversation. But there's a lot of things you can do right now to make your life a lot easier. And those are some of the most beneficial for me refilling my tank as an informaticist, is to show somebody something and them say, wow, I didn't know I could do that. This is incredible. You just saved me hours of my life. So I think on the one hand, just doing the basics well to make sure everybody understands the system that you have, which is not a simple thing to do because it's constantly changing. We're constantly getting upgrades, and busy clinicians are not focused on the 3 to 5 hours, I think, a year now that's recommended of ongoing training, but they're like, I have to get my CME done so I can remember how to be an emergency physician. This is not on my radar. And so convincing people that it's worth your time to just learn your system and make sure you know it deeply is really important. So I think on a fundamental level, it's important to get your foundation set well, which I think we don't do a great job of. I think people generally don't know how the system works. But in addition to that, on the more innovative and exciting front, I'm personally very excited in the whole ambient listening world, which seems like it's taken a giant leap forward since all the LLMs have gained popularity in the last couple of years. So I really think there's a huge amount of potential for taking natural free text data and making it discrete, which that's what irritates clinicians the most, is taking something natural and clicking a box so that someone else can measure it. It just frustrates people. And so if you can do that in a natural way and allow doctors to look at their patients instead of the computer screens and do what they do best, and then come back to a system that has filled out all their documentation discreetly for them in a 95% or almost 100% accurate way, and then review it and sign it, I think that that's going to do a huge amount of good to improve burnout. Maybe I'm drinking the Kool-Aid and it won't actually pay out, but it feels like we're on the cusp of something important here.
One of the lessons that we've heard talking to other CMIOs who've been deploying ambient and see what the uptake is like, is that there's different types of clinicians who gravitate more or less towards ambient. And so I think one of the things we've heard is it's not for everyone, and that's okay. The goal isn't necessarily 100% clinician adoption. But I'm curious, when you think about deploying technologies to frontline clinicians, whether it's ambient or some other tool, how do you think about success in terms of adoption? Like, what is good enough of adoption for you to continue something for clinicians versus, you know what, it's not getting enough traction. Maybe the maintenance isn't worth it. We should just sunset that tool. I'm curious what level of adoption is needed to keep something going clinically.
Yeah, it's a really good question. I think anytime you start to set up a pilot, you need to have some pretty clear metrics of success. I also 100% agree on the ambient front, just to focus on that for a second. I don't think 100% of providers will ever use an ambient listening technology. I always think about the orthopedic surgeon who does mostly knee replacements, and they have a template that has like 3 areas that they have to document something, and they have little asterisks, and they hit F2 3 times, their note is done. Yeah. They're never going to benefit from this technology. Now, I understand that the orthopedic surgeon visit is much more complicated than that, but then again, for somebody like me in the emergency department, I think it might be very helpful to take a very broad history and sort of synthesize a patient's sometimes rambling history into something more cogent. It could be really beneficial. So I don't think the right metric of success is even a percentage of users. I feel like it's the basic return on investment calculation, and that investment isn't just money, it's also people's time and their opinions of it. So, as we're thinking about structuring our ambient listening pilot, things we're looking at are, at a fundamental level, how much time does it reduce in your note writing? So time in notes is a very clear number there, and it better reduce your time in notes or else we're not accomplishing a whole lot. And then satisfaction of the provider, pre and post, how much do you like it? How much do you feel like it's removing your cognitive burden, which is sort of a hard thing to measure. And then also patients. Does it improve patient satisfaction? I think there's a real likelihood to have a patient enjoy their interaction more with a physician who is staring them in the face and not typing on a computer. There's also some general financial ROI where you might be documenting a more accurate clinical picture, and you might be able to bill higher for that. And also, by the way, check off more quality boxes and get your case mix index more appropriate for what you're actually seeing. And those are just some of the things I'm actually thinking about. But I think each technology is different. And so you have to think deeply about how that technology is going to work. And for ambient listening, I think those are the main ones. But I wouldn't just put it into a number of users category, which is also, by the way, one of the challenging things about informatics is that everybody does things differently. And so you want all these options available, but then you also get the users who are frustrated because there's 15 ways to do something and they just want one way to do it, and they're frustrated about that. So It's a very small needle that we're trying to thread here.
Today's episode is brought to you by Seamless MD, which enables health systems to digitize patient care journeys, leading to lower lengths of stay, readmissions, and costs. Josh, you used to be a doctor. Did you ever feel like patients showed up unprepared for surgery? Or maybe you felt like you were sending patients into a black hole after discharge?
All the time. We give patients paper and verbal instructions, which are so easy to forget and really hard to follow. And we have no idea what happens to them outside the hospital. So what happens? Well, because we worry about them, we keep patients in hospital longer, but that drives up length of stay and lowers throughput. Plus, after they leave, patients get readmitted for infections and all kinds of problems that we could have just caught earlier if we monitored patients.
What if I told you there was a way to give every patient a virtual companion so you could automatically engage and monitor them through a surgery, a cancer journey, or a chronic care journey, and drop the length of stay, increase throughput, and lower readmissions?
Gosh, Alan, that would be amazing.
So that is exactly what Seamless MD does. It allows health systems to engage patients on their own phone, tablet, or computer with automated reminders, education, and symptom monitoring. Basically a GPS through any healthcare journey.
That sounds fantastic, but does it actually work?
It does. Health systems have done over 40 studies and evaluations showing how they use the solution to reduce length of stay by 1 to 2 days, readmissions by up to 89%, and costs by over $1,000 per patient.
But how does that work with my EHR?
That's the best part. Seamless MD is the only solution in this space with direct integration partnerships with Epic and MyChart, Oracle Cerner, and Meditech.
Well, I am getting a colonoscopy soon, so I really need something like this. Where can my health system learn more?
Well, Josh, thanks for letting me know. Your health is very important, and endoscopy is just one out of the 50+ out-of-the-box care plans available today on Seamless MD. Go to www.seamless.md. That's www.seamless.md to learn more.
I had a follow-up question that I'd love to get your take on. So I think for folks who are outside the clinical world, if you've never been a clinician or worked closely with one, you often assume that if a tool can free up clinician time, then clinicians will just want to see more patients or do more clinical things. But I suspect that for most clinicians, if you can actually free up their time, they'd either want to spend more time per patient or to have space for non-clinical things. Maybe that's just to get home on time to see your family, or maybe to have opportunities to do non-clinical things with that time. Could you kind of share any feedback on that? Is that an accurate take of how clinicians really feel about if you can free their time up, or am I missing something?
Yeah, no, I think you hit the nail on the head. There's nothing I feel like more irritating to a clinician who is burned out to go to them and say, here is a technology that will free up your time so that you can see more patients. Like they're already struggling and they want to provide the highest quality care to the patients that they're seeing. They also want to have a reasonable work-life balance. And so I don't think there are that many lazy doctors who just need to see more patients. I think everyone's working as hard as they can, and these kinds of technologies help them to fill up the parts of their bucket that aren't getting full. And generally that's getting home to see their families, and also to be able to spend the time on patient care and not on the bureaucratic administrative tasks, which is what got everybody into medicine in the first place. So I'm really hopeful that these kinds of technologies will both allow for better clinical care and also better work-life balance for the frontline caregivers.
Excellent. So, David, I wanted to also ask you about wearables and device-based virtual care. I know you've been a big proponent on that. You've done a ton of research on both of those fields. I'm curious, what have been kind of the most surprising learnings that you've had from the space of, say, virtual care?
Yeah, so I got really interested in wearables and virtual care kind of during COVID. We did some research putting continuous monitoring devices on patients, those little EKG patches, like a 1-lead ECG, which also gets some triaxial physical movement data. You can get steps, you can get respiratory rate, things like that. And then it's sort of a continuous stream. And so we did some research early on in COVID to try to predict decompensation, because at that point it was very difficult to know exactly who was going to crash and when, and there were lots of space constraints in the hospital. It really opened up my eyes to how much of the patient experiences outside the hospital, because people don't come to the hospital most days of the week, and they live their lives outside of the hospital. And so the emergency department, we see patients hopefully, one time in a year or less. Primary care providers see them much more often. They have a relationship built with those patients, but even primary care doctors, you don't see them every week unless you're very significantly ill. And so you're missing this huge swath of data where the patient's just doing their normal thing. and you're relying on them to hopefully synthesize it and tell you the most important thing when they see you in the clinic, and relying on that one blood pressure reading where they see the doctor and start getting nervous about what their blood pressure is going to be. And so is that even accurate? And so it's a really interesting space to get a fuller picture of the patient. One of the things I think that surprised me too, though, is because of the volume of data that you get, if you're sending measurements on ECG recording for a month, that's every millisecond of data. It's just extraordinary amounts of data. And so what do you do with it afterward, I think, is the critical piece. Just having it isn't all that helpful. You have to have a plan. How often are you looking at it? Who is looking at it? Does it need to be a physician? Is it an advanced practice provider? Is it a nurse with a certain set of protocols? What does like a virtual command center look like? And what kind of questions can you answer? Because with that much data, you can kind of get statistically significant result that might not be all that meaningful just because there's so much data. So I think it's still a bit in its infancy. I think the technology continues to improve, and it's particularly helpful with chronic disease management like congestive heart failure and things like that. I can also say that I continue to just be nerdy and interested in it. I am currently wearing 2 wearables. I have the Apple Watch and a Whoop bracelet on, and I don't have any particular affinity for any one wearable or another. I just was curious how they worked with each other and the sleep monitoring. And so, like, even for healthy folks that don't have a chronic disease they need to manage, I think there's a lot of power in your own data. I kind of know when I'm exhausted, but I look back and I'm like, wow, I really only got 3 or 4 hours of sleep the last couple nights, and I really need to take it easy for the next couple days to catch up. I think there's a lot to be said just for managing your own personal life, even if you're generally well.
Yeah. No,
I think
great points.
Yeah, I was going to say, David, I think one of the interesting things to your point is with all that data, it's a question of how do you use it to make it meaningful? Because I can imagine also, even within a single department, you could have a clinician who, wants all the data, who wants to get alerted for every little thing about their patients. And then in the same room, there's another clinician who wants none of that data. And so I can imagine it can be very hard to have a standardized approach to how you use that data within a single division or department, let alone like how could you support all kinds of variables and use cases to that. So that's really interesting. Hopefully you're not automatically alerting your PCP based on your wearables. I don't know if they'd be okay with that, but
No, I'm not. And it's actually interesting because I have a lot of friends and colleagues who are PCPs, and I think there's a real concern for people just plopping a wearable on and then dumping the data on the clinician who doesn't even know it's there and then feels responsible for doing something with it now that it's there. So I think the right way to do this is to have the conversation between the provider and the patient, and then have some formal like order that sort of initiates this thing on the provider side so that they are expecting the data and they have a plan. They've talked to the patient about how they're going to be viewing this. And I think all this can be done, if you try to roll out a program, you can standardize the way that these things are viewed. But I think we're still in the infancy of trying to figure out what the right mechanism is. And I think it makes people uncomfortable sometimes to have all of this data out there all of a sudden. And you're like, well, now I got to look at it 20 times a day. Or you could take the perspective, the patient has been having those same heart rhythms with no one watching them for decades. And so just because the data is there doesn't mean you're obligated to look at it every single second. It's net good whenever you do look at it. But those conversations are tricky because when it is there and you could look at it, it does change people's perspective.
I think to your point, it comes down to setting those clear expectations with the patient, because it's when their expectations are mismatched, then you get into trouble. If they think you're looking at it all the time and you're planning to do that, then folks get upset. But if you're all on the same page, then I think most people would be okay with whatever cadence that is of checking the data. That makes a lot of sense. You brought up ambient before, and in general, we know that AI is a pretty hot topic among healthcare leaders right now. Besides ambient, kind of curious if there's any other low-hanging fruit, high ROI use case that's top of mind right now. Is there any other use case that you think actually is overhyped and maybe shouldn't get the attention it's getting in healthcare?
Yeah, so I think we're similar to a lot of other organizations where we've dabbled in the in-basket generated draft replies. I actually think that one may be a little bit more overhyped, although it's still a little too early to tell. I think our pilot so far has gotten sort of mixed results. We only rolled it out to a very small number of physicians who were all sort of affectionately referred to as the nerd physicians, who kind of understood the technology, but they also had a lot of like other research interests and didn't have super busy clinical schedules. So I'm not sure that they were the best ones to show the value. And then we just opened it up to our nursing staff because the nurses on the front line and were actually taking care of many of the messages, the bulk of the messages before they got to the physician. So we felt like, let's give it to the people who are doing the bulk of the work. And so preliminarily, I think it's a bit more helpful in that setting. So I think the jury's still out on it in general. We're very excited about ambient. We're also about to embark on some pilot work within the note summarization space. This is one of the things that I was excited about when all this stuff first came out as an emergency department physician, because you see a patient who shows up with a very complex, prolonged medical history, and it's 5 or 10 minutes before I see the patient, I go and parse through their notes, look at a discharge summary or two, but there's no way I can synthesize all the relevant information, particularly with the context of what their question and their problem is, because maybe they have a lot of complicated kidney issues, but they're coming in because they sprained their ankle. But the ability to synthesize all of that huge amount of data and present it in a contextual way, linking back to the resources, which I think is really important to make sure that you trust it, I think has a lot of potential. So we're going to be working on the inpatient version of that and then potentially generating discharge summaries. Just the whole AI governance thing is very complex too, because there are so many opportunities right now that one of the things on our next AI governance meeting agenda is just to look at the current roadmap from our vendor about all the possibilities and say, just because there are 70 things that are available does not mean we're going to pilot 70 things. And so we have to pick the items that align with where our organization is trying to focus right now and do 3 or 4 things well instead of trying to do 70 things and being all scatterbrained. So I think right now the name of the game is focusing in on what's most important and what will help your organization.
Well, I think you have a really good point around like who the right early adopters are for some of these tools. Because you mentioned maybe some of the, let's call it nerdier or tech savvy clinicians who may put their hand up first, but may not be representative of the folks who could benefit the most. I'm reminded, my brother's a primary care provider, and over the weekend I was saying, hey, would you consider, being the first in your clinic to, pilot something like ambient? And his immediate reaction was no, because I think for him, actually, he's tech savvy, he's a system in place, and it's just not a pain point for him. So even if he could, figure out how to use it the quickest, he just wouldn't have that, long-standing need for it, and he won't sustain his engagement. So you almost want to find that right sweet spot of they're savvy enough to engage, but they actually have a real pain that it could solve so that you could see the impact on the improvement, you get that sustained usage. That's actually a really good point. I think oftentimes you try to focus on the early adopters who just are tech savvy, but that may not be the right audience to start.
Another way of framing that is I think you need a little bit of each. So I think you need 2 or 3 super tech savvy early adopters that can actually push the envelope and give good feedback to the developers and say, your solution is great, but it's failing on this 1 or 2 points. And so I think that's important. And then you also need people at the other end of the spectrum who are really struggling that will have the biggest benefit if they can learn it. But you don't want only them, because some of them have multifactorial issues about why they're struggling. Like it might be that the technology isn't the thing that they need the most. They may just need more staff in their clinic or something. And then you also need people in the middle. So I think you need a representative sample from your organization to try to get feedback from all those different groups.
That's a fantastic point.
Yeah. So David, last question that I had, and this relates back to when you were first mentioning about the EHR and some of the untapped potential that maybe clinicians aren't aware of within the EHR, but then also with your various RPM initiatives. I'm curious, what are some strategies you've found to be effective in increasing awareness on the programs themselves or the functionality of each of those programs?
And I wish I had a good answer that was simple to that question, because getting people to understand the systems that they use is really tough, because they rightly are busy and focusing on patient care. The thing that I found to be most effective is also the least scalable, which is walking around and talking to people. So you really need that personal interaction so that you sort of force them to not just glaze over the email that you sent or not watch the video that you put together, but you're interacting on a human, professional level, colleague to colleague. So it's really that super user concept. And so we're really trying to grow our super users to not just teach them what to do, but then empower them to go tell their colleagues. And so I try to do as much rounding as possible and just ask people. But the other interesting piece of that is you can't just round and say, hey, how are things? And then people say, hey, fine. But it's like they're not fine and they don't even know what good looks like. And so they don't have the questions to ask. It's also important to come with 5 or 6 things in your tool belt. What we've gotten into the habit of doing is we have these frequent upgrades. And so we try to take the top 5 upgrade changes and literally just walk around to all the patient care documentation rooms and say, hey, checking in on how things are going after this last upgrade. Did you know that you can do these 5 things now? By the way, how are things going? And try to have a conversation and then just, getting to know your colleagues and having that open lines of communication. But I really have struggled with any other form of communication to get doctors to pay attention to it. They're just busy and they don't read their emails as often as I would like them to. And the tip sheets are just not as effective as we like to think they are.
Yeah, you're in this weird spot where you have so many users, but unlike other industries where all these users may be at their desk 80% of the day, you're in the opposite situation where their desk, I don't know, less than 10% of the day maybe.
Yeah.
So when you go around, like, are they even going to be there in the patient care rooms when we want to get feedback? And 2 is, even if they're there, are they with it enough or available enough to engage and get feedback, let alone read their emails that you send? Yeah, that's a tough crowd to serve.
Yeah, and we definitely try to target different areas. Like, you don't want to go to the inpatient units right in the middle of rounds. You don't want to go bother the surgeons during their 6 a.m. first case on time start. And so you're right, it's a delicate balance. I wish I could find more free time for physicians so that I could teach them about the EHR, but it is a hot commodity.
Yeah. Well, David, speaking of limited time, just want to be mindful of your time. We're going to flip over to what we call the Fast 5 lightning round. This is just 5 questions to get to know you better. The first question we have is, what is your favorite book or book you've gifted the most?
Yeah, I think one of my favorite books is Factfulness by Hans Rosling. And it's basically, he makes the case that if you really dig into the data, the world is not quite as terrible as it sounds, and not to minimize the current problems that we have because they are significant, but we've never been better off than we are today. So it's a very empowering book because I think it allows you to dig into data and also have an optimistic view of the future without ignoring the current problems, which I think is an important viewpoint to have.
Yeah, I love that. Question 2, who is a person, either dead or alive, who you'd love to meet?
Yeah, I am really interested to meet Barack Obama. He was sort of rising right as I was in medical school. And so there are so many things that happened during his presidency that I just would like to know the inside story, because there's things that politicians say to everybody, and that there's just some really interesting insights I bet that would be there. And, now after the fact, after he's been out for so many years, and his perspective on current events, I just think he's an interesting guy to talk with.
Yeah, no, definitely. Question 3 is a bit different. Would you rather have super strength, super speed, or the ability to read people's minds?
And this is so tough. I was going back and forth about this one, and I think my initial reaction was, man, I want to be able to read people's minds. And then I got very terrified because I work in the emergency department, and people are not always well put together. And so, I think that might be too much. And so I think I want the ability of super speed.
Yeah. Question 4, what is something in healthcare you believe that others might find insane?
Yeah, so I think for this one, it's the fact that your mental and physical health, you just can't separate them. I can't tell you how many times the two relate. Not to say that your physical problems are just in your head or vice versa, but you can't think about one without thinking about the other. Your physical pain affects your mental state affects your physical body. And so I just think the way that those two things interact is complex, and I don't think we pay enough attention to it.
That's a great point. Last question that we have, David, if you could travel back in time to any event or moment, what would it be and why?
Yeah, I think this was a hard one for me because I think I'm really like a sci-fi nerd, and I'm like so excited that we're getting close to like general artificial intelligence, things like that. I'm so forward facing, but anecdotally, I'm watching the For All Mankind, sort of that historical science fiction drama thing about what things might have been different with the moon landing. So I think that's on my mind, and I would love to go back and like be able to be one of the first people to set foot on the moon or just experience that with everybody. I think it'd be really exciting.
Yeah, no, that'd be awesome. I did a demo of the new like Apple VR headset, and like part of that demo is, I get to go on the moon now. It's like, wow, that's incredible. Yeah, that would be really awesome. Well, thank you so much, David, for your time today. You've shared just a ton of wisdom with us and our audience, and I'm really appreciative of you taking the time to spend with us. That's a wrap for this episode of The Digital Patient, hosted by Seamless MD. You can follow us on Twitter at SeamlessMD. And if you like the podcast and you want to learn more, visit www.seamless.md. Again, David, Dr. Chestek, thank you so much.
My pleasure.